Assalamu alaikum. My name is Dr. Umair. I am presenting oncocytoma and other benign renal masses. In oncocytoma, it is 3 to 7% of renal tumors, and according to recent studies, its incidence is increasing in older age patients and in females. The most common genetic abnormality is the loss of heterozygosity of chromosome 1 or 14. It arises from intercalated cells of collecting tubule. Usually, they are sporadic but can be seen in Birt-Hogg-Dube syndrome. Usually they are asymptomatic and are diagnosed incidentally, but can present with gross hematuria, flank pain, and on examination a palpable flank mass. In 13% patient, it can be multiple. There is a renal oncocytosis. In this, the presence of multiple concurrent renal oncocytoma with or without RCCs. In up to 30% cases, oncocytoma and concurrent RCC may coexist. On gross appearance, they are well circumscribed cortical mass with a pseudocapsule and a stellate scar that is present in about 1/3 of the patient. This one. Usually diagnosed on histology, which shows large, uniform, highly eosinophilic, which are due to increased mitochondria, eosinophilic cells arranged in distinct nests. Eosinophilic variant of chromophobe RCC and oncocytoma are histologically almost similar. And additional tumor markers, additional immunohistochemical stains are required to differentiate between them, like CK7, which is positive in 66% of RCC and only 5% of oncocytoma, and parvalbumin in 100% RCC and 47% of oncocytoma. In Birt-Hogg-Dube syndrome, both RCC and oncocytoma coexist. Chromophobe RCC is also derived from renal tubule, and both have similar age of presentation, almost 7 decades of life. Both are common in females as compared to male, 2:1 ratio. These are the nests of eosinophilic cells. On imaging, usually they are diagnosed incidentally. On ultrasound, well circumscribed solid mass with echogenicity similar to the rest of the kidney. On non-contrast CT, well circumscribed renal mass, usually with heterogeneous attenuation and calcification. In CT with contrast, in a nephrographic phase, a mass shows a hypoenhancement, while non-enhancing stellate scar is present in 1/3 of the patient. On angiography, typical spoke wheel pattern is present with sharp demarcation of tumor from kidney and surrounding areas. On MRI, T1 hypointense compared to renal cortex, and on T2 it is hyperintense compared to renal cortex, and it may show a hypointense stellate scar in 1/3 of the patient. And this one is a large oncocytoma kidney. And they usually have excellent prognosis. These tumors are usually benign but rarely reported with liver mets. In 2018 in Japan, a case report published in which patient had oncocytoma with a tumor thrombus. That is the only one case report I could find. So in 20 to 45% of small renal masses are found to be benign. Usually active surveillance is often offered to the patient. In most cases, for older and sick patient, observation is required, while in younger and healthier patient, treatment is by surgical resection. Due to benign nature of these tumors and low recurrence, nephron-sparing surgery is usually indicated, like partial nephrectomy. Frozen section analysis also can differentiate between oncocytoma and RCC, so usually it's not used because additional immunohistochemical stains are required. And the second one is the Metanephric adenoma. It is a rare benign tumor, only 0.2% of renal mass. It is more common in female with weak incidence in 5th decade of life. It is also mostly diagnosed incidentally, while in 10% of patients, it is present with polycythemia, that is due to erythropoietin production by the tumor. Recent studies show that 90% of these mutations have BRAF V600 mutation. This mutation is also present in melanoma and colorectal carcinoma. On ultrasound, they appear as hyperechoic mass. On CT with contrast, they appear as hypodense or isodense with poorly defined margin and less enhancement than medulla and cortex. Sometimes calcifications are also present. On histology, very small basophilic epithelial cell that form acini or tubular structure with predominantly acellular stroma. These are the basophilic cell forming a tubular pattern with the acellular stroma. These tumors sometimes show regression in the form of calcification or scarring. It is basically a pathological diagnosis, like immunohistochemical markers and percutaneous biopsy increase diagnostic yield and helps in differentiating it from Wilm tumor and papillary RCC. Treatment is used by surgical resection, and diagnosis is confirmed post-operatively by additional tumor markers like cytokeratin, WT1, and S100. Cystic nephroma, it is a rare benign renal tumor. It is a bimodal age distribution. First peak is at the age of 2 to 3 years, where it constitutes 2 to 3% of all primary renal tumors seen during childhood. Second peak is in 4th to 5th decade of life with female predominance. In literature, reports of sarcoma and clear cell carcinoma arising from cystic nephroma are present. On gross appearance, solitary multi-septated mass of fluid-filled oculi surrounded by thick capsule. These are the cystic spaces of cystic nephroma. These are lined by capsule. On histology, cyst lined by flattened cuboidal or hobnail epithelium with thick fibrous pseudocapsule. Immunohistochemical staining is positive for cytokeratin, which shows epithelial component, and CD10 calcreatinin inhibin estrogen progesterone, which is positive for stromal component. They are also mostly diagnosed incidentally, but it cannot be reliably distinguished from cystic RCC in adults or worm tumors in children. On CT scan, it shows multilocular cystic mass with well-defined margins, often showing a herniation into the renal collecting system and septal enhancement. This one is the nephroma. Due to concern for cystic worm tumors, treatment in children is mostly by radical nephrectomy and in adult by partial nephrectomy. And then it is confirmed by postoperatively immunohistochemical stains. Mixed epithelial and stromal tumor is a rare benign renal neoplasm. It is a biphasic adult renal lesion containing solid and cystic areas. It is called biphasic because it has both solid and cystic component. Composed of spindle cell stroma and epithelium that lines the tubule and cystic spaces. It is more common in female, 10:1 ratio, usually in first decade of life. It is mostly common. Most of the patient estrogen seems to play important role. It has been more common in perimenopausal women who are on hormone replacement therapy. On gross appearance, encapsulated mass of variable size ranging from 2 cm to 24 cm, usually involving renal hilum with compression of pelvic ileal system. On histology, show variable admixture of both epithelial and stromal component. On immunohistochemical stain, epithelial component is usually positive for cytokeratin and stromal component is positive for estrogen and progesterone receptors. It usually follows benign course, but few cases of local recurrence of malignant stromal component and one case of malignant transformation to sarcomatoid carcinoma has been reported. On CT, it appears a complex cystic mass with variable proportion of solid component, typically classified as Bosniak class 3 or 4 lesion, which are indistinguishable from cystic RCC. Surgical intervention with nephron sparing surgery is offered to patients. Then again, Leiomyoma. It is 1.5% of all benign renal tumors. It can arise from smooth muscles anywhere along the urinary tract, but in kidney, most common site is renal capsule. On gross appearance, it is the firm, well-encapsulated solid mass arising from the kidney. This is the one Leiomyoma arising from the upper pole of the kidney. On histology, it shows spindle-shaped cell with cigar-shaped nuclei without any pleomorphism and hypercellularity. And these are the spindle cells and without any pleomorphism and hypercellularity. Most of them are also diagnosed incidentally. Ultrasound may display a solid or cystic mass and allow for identification of planes between the tumor and the kidney, but has very poor specificity. On CT, they appear as exophytic renal mass with a capsule or subcapsule with capsular or subcapsular or peripelvic origin. Minimal parenchymal distortion and no evidence of extrarenal invasion is seen. Chromophobe RCC and Leiomyoma have similar contrast enhancement on a CT scan. The immunohistochemical markers specific for smooth muscle like desmin and chaldesmin are positive in both of them. Some Leiomyoma stain positive for HMB45, which is typical for AML, angiomyolipoma, is suggesting a possible link to angiomyolipoma. Treatment for larger lesion is radical nephrectomy, and for smaller and peripherally located lesion, nephron sparing surgery is done. Papillary adenoma is a small renal epithelial tumor with benign course. The current WHO classification defines renal papillary adenoma as unencapsulated epithelial tumor lesion with a tubulopapillary architecture measuring less than 1.5 cm and of low nuclear grade. Its incidence increases with age and is more common in males. Associated with patient of end-stage renal disease due to renal cystic disease. It may be linked to the development of papillary RCC as it shares similar immunohistochemical staining and cytogenetic profile with papillary RCC. These are associated with when they are associated with RCC, they are mostly multiple in numbers. On basis of further studies, it was said that papillary adenoma could lead to the development of papillary RCC and can be considered as pre-malignant lesion, which can lead to development of papillary RCC. On histology, it shows uniform basophilic and eosinophilic cells arranged in papillary tubular or tubulo-papillary architecture. And this is the one less than 5 mm tumor with tubulo-papillary growth. The majority of patients are asymptomatic. Most of the tumors can be detected by imaging as they are less than 1 cm. Size of renal adenoma has been used to differentiate it from malignant tumor. Mostly these are kept on observation for the size of the tumor. Juxtaglomerular cell tumors, Leiomyoma, it is a benign tumor of juxtaglomerular cell. Fewer than 100 cases total have been reported so far. It is mostly in female in their 3rd and 4th decade of life. It leads to increased renin secretion, which lead to hypertension because of increased sodium absorption, and hypokalemia because of increased potassium secretion, and associated symptoms like polyuria, polydipsia, myalgia, and headache. On lab testing, it shows increased plasma renin level, secondary hyperaldosteronism, hypokalemia. On imaging, a small, usually less than 3 cm solid hypovascular mass. On histology, sheets show sheets of polygonal to spindle-shaped cell with indistinct cell borders and eosinophilia and minimal atypia. On immunohistochemical staining, factor 8 and factor 8 related antigens are present which show its endothelial origin. Treatment is surgical resection, usually by sparing remaining renal parenchyma, mostly by partial nephrectomy. Surgery results in rapid resolution of symptoms and correction of biochemical derangements. Hemangioma, it is a benign vascular tumor, mostly in young population, usually sporadic but may be associated with syndromes like Sturge-Weber, which are associated with hemangioma of the face or other sites. Typically, it is a single and unilateral, located near the pelvis or renal pyramids. On gross appearance, it is a spongy red and like definite capsule. Microscopically, irregular vascular spaces lined by single endothelial layers. Treatment is usually by embolization in case of small, and in case of large, partial nephrectomy, or in few cases, nephrectomy is required.
So, audience, any question regarding the presentation and any queries about the topic?
If you remember, 2 weeks back we had discussed one presentation, that there was a case, and it was of a child, probably 9 years or 10 years of age, and this article or this presentation is also in league from that aspect also. At that time, what happened was we were in a fix whether it was something of related to trauma, or it is something which is actually a tumor. And nobody thought about a renal cystic lesion, which might be a variant of Wilms tumor, because the child was of that age. And since we are not in the process of thinking about things other than renal cell carcinoma these days, we are always in making two decisions, one of the two. One is either we should go for partial nephrectomy, or the second is we should go for a radical nephrectomy. There is no third option or fourth option, but there are many options now. The subject of renal tumor or renal mass is now quite open in the sense that there are many options. You have to select each option according to the pathology that you think in your differential diagnosis. So now it's not the case that every tumor, for instance, since the time when I was at your age, it was thought of like 90% of the tumors of the kidney, they are renal cell carcinomas. So there is no other option. It is not chemosensitive. It is not radiosensitive. We only have to think about surgery. Now, if surgically it is possible to have a plane, to have something called radical, then it is something which is very good. At that time, it was not an option to do partial nephrectomy because the criticism was, if you do partial nephrectomy, then either you should do frozen section or you should actually be leaving a lot of pathology behind, and that can give rise to recurrence. So it was something that once you have a patient of a renal mass, you should not do any biopsy, because the biopsy will tend to implant the tumor cells in the trajectory of that smaller needle that goes through the skin and into the kidney and then come back. So there were a lot of things that were actually contraindicated. And we were in a process of thinking just two things, or rather one thing: surgery or no surgery. But now you see, the natural biology of the tumor is very much understood, and many of the things are becoming clearer by the day. There are newer strategies in terms of TKIs and things like that. And now you have to select your patient whether you should go for new adjuvant therapy with TKIs or you should go for surgery up front. In the realm of surgery, there are again many options, whether you should go for partial nephrectomy or you should go for a nephron sparing surgery. In a metastatic scenario, what should be the option first and what should be the option next? So you have to select a lot of things. For instance, in the context of oncocytoma, since oncocytomas are those tumors which are very common in the sense that amongst the list of benign tumors, they are common, and they have got a coexistence with the renal cell carcinoma. For instance, if you operate on a patient with renal cell carcinoma having the clear definition of central necrosis on your imaging, then you might get a focus, another focus in the same kidney or in the other kidney of oncocytoma. There is no malignant potential or conversion of oncocytoma from its presence into renal cell carcinoma, but there is an association, probably a neighborhood association. So whenever you have got oncocytomas, for instance, less than 3 centimeter or 4 centimeter, and there are certain things, for instance, for any tumor in the kidney, you would like to do something called a triphasic study. Now, if you got a picture of arterial phase, then you will have a peculiar picture, and that is known as spoke wheel appearance. Now, if you happen to see that appearance on any picture, in any book, in any article, then that remains in your mind. And whenever you see the CT scans for a renal tumor, if there is something at the back of your mind that there is some pathology or say morphology which is like a spoke wheel appearance, and this is something which is vascular structure, vascular architecture, then you will think of oncocytoma where surgery is not warranted. So there are many things which can be said, looked into, and think about in pre-diagnosis rather than going into surgery and then see what it is on a post-surgery biopsy specimen. So many things can be said about it. So in these days, if you are practicing and you are appearing for exam or doing your practice after exam, these things do come up. These questions do come up. So please broaden your horizon, look around you, and change your thinking process. It's not only 2 options now. There are many other options also, and every patient would ask you, what are the options? So you must be very much clear in your mind at which level you would go towards something called SIUT, which is TKI, and surgery. And for surgery, what kind of surgery you would like to propose to your patient, because now patients are intelligent. They do a lot of, probably it's a guesswork rather than homework, but they do have something with them and they will ask you a lot of questions. So as As a person who wants to deal with these cases, as a doctor, as a urologist, you must be aware of options, and you must be confident of all the thinking process behind each and every option. So the picture is now a little bit complicated compared to what it was 10 years back. So,
actually, it's not all about the surgery. We have to diagnose it first. Like you said, that pre-op biopsy is very important, because most of these tumors I was reading, they are very difficult to diagnose on radiology. They are very low accuracy on radiology, so we have to diagnose on pre-op biopsy, and
yes, and most of the
active surveillance or surgery we can offer them.
Yes, most of the times we urologists always rely on our radiological colleagues, and they would give us in their statements something which they see. But now, since the thought process is such that we rely on their statements 100%, so now they are telling us to go for surgery or you shouldn't go for surgery, and that shouldn't be the case. I mean, their domain is only to explain what they see. Their domain is not to suggest what we should do. And that thing appears whenever we have got some weaknesses in our own system, in our own capacity. So if surgeons are in the process of just relying on what the radiologist is saying and don't putting themselves into the process of thinking, then these things do happen. Then anybody can just say to you that you should do this thing, and I think that you shouldn't go towards that direction. Now, that shouldn't be the case, because everybody has got its own expertise, and the expertise stops at the point where the other expertise starts. So this is my gut feeling and my, say, reservation about the whole subject. Whenever you read a CT scan or an MRI about any pathology related to urology, since that is your field, then you must have your own opinion, and that opinion should be yours. It should not be influenced. It should not be rather. You should always take into consideration every aspect from any of your colleagues. But you should make your own opinion, and that opinion should be justified, and the justification comes whenever the result comes. So first make a point that you must have an opinion. Whether it is relevant or irrelevant is something which is the next step. It's not the first step. So don't hesitate to make an opinion. You should all be making an opinions of yourselves, and that would make you confident. And confidence is the thing which we all need in our life. Thank you.
Thank you.